countries who are on today's call with us here. Before we get started, I would like to go over a few items so you know how to participate in today's webinar. You may have joined the presentation using your computer speaker system by default. If you would prefer to join over the telephone, just select phone call in the audio pane and the dial-in information will be displayed. Please ensure that you are on mute during the presentation and when you're not speaking. There will be opportunities for questions at the end of the presentations. We'll save all questions and discussions to the end of the session. You'll also have the opportunity to submit text questions to today's presenters by typing your questions into the chat panel. You may send in questions at any time during the presentation, and we'll collect all these and address them during the Q&A session at the end of today's presentations. For the Q&A session, we'll open the floor to allow discussions on points raised by today's speakers, as well as share center of excellence, country experiences and perspectives on TB data use. It's now my pleasure to introduce you to today's chair people, Professor Jane Carter and Dr. Enos Maseni. Professor Jane Carter is a professor of medicine at Brown University in Providence, Rhode Island, USA. She's a former president of the union and has focused her career on TB treatment and prevention and medical education, both in the US and internationally, primarily in African settings. After partnering with the union's training department and Dr. Richard Lodlow to teach in the union's TB principles course in Zimbabwe, where she participated in field training around data use, she's become a vocal advocate for TB data for action approach to use local data to improve the quality of care for TB patients. Our second chair is Dr. Enos Masini, who is a public health expert, currently serving as a senior disease advisor for TB at both the Global Fund and the Stop TB Partnership in Geneva, Switzerland. He has previously served as Kenya's National TB Program Manager and at WHO in Kenya. I'd now like to hand over to Professor Jen Carter to take us through the next sessions. Over to you, Dr. Jen.
Thank you, John Paul, and welcome to our distinguished speakers and participants from across the region. National tuberculosis programs have a wealth of data in their registers that are maintained at different levels of health services and in the periodic reports that facility, secondary, and tertiary levels submit to the central level. These data are infrequently used meaningfully for clinical and programmatic management or for operational research. The NTP in Zimbabwe, together with the Union, has developed an approach for data analysis and use by health professionals at all levels of services to increase both TB case finding and to strengthen the quality of services. Routine support supervision and performance review meetings have been remodeled to include a strong data-driven component to ensure that these activities also contribute to the improvement of TB care cascades. The approach has also been adopted and adapted by the NTP in Kenya. CDC, in collaboration with several NTB programs such as Nigeria and India, has also developed dashboards to facilitate similar review of local data to assess the TB care cascade, which may drive programmatic decision-making. In today's webinar, Zimbabwe and Kenya will share lessons learned on TB data for action and how local staff can use their own data to find more children and adolescents with TB and strengthen the quality of TB services and how data-driven support supervision improves TB care cascades. CDC will also provide a short introduction to the DICE Toolkit, a modifiable and fully adaptable Excel-based toolkit for assessing TB care cascades, particularly for people living with HIV, and Elevate, a data dashboard designed specifically for India's Nikshay TB surveillance system for real-time cascade analysis and program action. After the presentations, we will have a Q&A, discuss and share experiences and perspectives from all Center of Excellence member countries present on the webinar. Now over to my colleague, Dr. Enos Mussini, to introduce our first speaker. To you, Enos.
Thanks, Jen and Paul. Good afternoon, everyone. And I think good morning also to colleagues in the US. Our first speaker is my good friend, Dr. Charles Sandy. Dr. Charles Sandy is a medical doctor with a master's degree in international public health. He is a deputy director in the Directorate of HIV, AIDS, and TB programs, responsible for leading the national TB leprosy programs in the Ministry of Health and Childcare in Zimbabwe. A position is held for over 10 years. He is, for all of us who have met him, know that he is passionate about scaling up accessibility and quality of services and that children receive, working closely with several partners like the Global Fund, the Union, and ECPA. Dr. Charles Sandy will be presenting on introduction into making sense of TB data, TB data for action, what, why, how, where, and when, lessons learned when rolling out this approach. Welcome, Dr. Sandy.
Oh, thank you very much, Enos, for that welcome, and good afternoon, good morning, ladies and gentlemen throughout the world. And also wish you a very happy entry into the new year. I know we have got COVID ravaging most countries, but we hope that we will all get through it. I'm going to share a presentation on how we introduced this approach of making sense of TB data in the country. The PowerPoint slides were prepared by the two godfathers of the approach. I would like to thank our M&D officer, Mr. Sizba, and our M&D officer from the union, Mr. Mlilo, who thought of this idea some years ago, and it has now evolved into what it is now. So next slide. So this is just a slide to show a bit of Zimbabwe. It's a teapot-shaped country with 10 provinces. 2 of the provinces are urban provinces. The rest are sort of considered rural provinces, and we have a total of 85 districts and over 1,700 health facilities. Next. Again, some country context for the TB situation. We are one of the high burdened countries of TB, according to WHO, with a very high incidence estimated at 199 in 2019. Treatment coverage was good, but for 2019 it came down. We also have a problem of HIV, where the estimated prevalence is about 4.8% amongst adults, and 2/3 of our TB patients have HIV, according to our data from 2019, though the coverage of testing of HIV is quite good, with 98% of patients getting tested. Next slide. This has been the trend of TB notifications in Zimbabwe, which just illustrates the impact of HIV, where from about 1988, as the HIV prevalence sort of increased, we also saw an emerging TB epidemic. But over the years, we have also been adopting global recommendations for TB, which we have seen the number of notifications coming down, though, of course, we still feel that we could be identifying more TB cases than what we are notifying. Next. So now, moving on to making sense of TB data. The background to this was basically what we saw as NTP, that there was a huge variability by provinces and districts with regards to timeliness, completeness, and accuracy of the data being submitted to the national level. And it was then noted that our healthcare workers had very limited appreciation and utilization of the health data which they were generating, as most of them actually felt that this was a burden, and so they didn't care much about the quality, and they felt that this was really a national level issue. So this innovation of coming up with this intervention was then developed in 2011 by the NTP, as I said, one of our officers, Mr. Sizba, and the union, Mr. Mlilo. And to support it from its inception, there was some funding from the Challenge TB mechanism. So this basically focuses on how to strengthen the skills and knowledge of the frontline healthcare workers, starting from the lowest level, which is the rural health center, the district hospital, as well as the provincial health executives. And it focuses on how to collect quality data, how to analyze the data that has been collected, and how to utilize this data for planning and decision-making at those levels. Next. So what prompted this concept? We noted that data was frequently collected and compiled mainly for the submission to the next level. And we saw a lot of challenges. When it comes to data quality, incompleteness was a problem, inaccuracy was a problem, and the data was generally unreliable. And then the healthcare workers did not think of linking the performance of their programs with the data that they were collecting. The healthcare workers also were not analyzing their data to identify what are the bottlenecks and what should we then be doing in terms of remedial action, or how should we prioritize the decisions to improve performance. So basically there was limited use by the sub-national level of the locally generated data for planning and decision making. Next. Next. So we came up with this concept, and the objective of the concept was to capacitate the healthcare workers and strengthen their ability to collect quality data, analysis of the data, and utilization of the data for strengthened evidence-based decision-making at local level. So there was a number of sub-objectives related to the main one, and I'll just quickly go through them. The intention was to see all facilities reporting timely, accurate, and complete data. The other was to build data ownership at local level. Once you have ownership, you also improve on the quality. The other one was to build confidence amongst the healthcare workers. Once they understand the technique and they know how to do it, then they have confidence in carrying out the analysis, in using the analysis for decision-making and planning. We also noted there was a lot of gap in terms of skills for verifying and validating data before use. And we also wanted to see a capacity of healthcare workers improved for them to identify what are their program strengths and what are their program weaknesses, and how to develop recommendations which are in line with what the data analysis is showing. Then we also used this concept. One of the objectives was to ensure that when supportive supervision is carried out, there has to be some basis for doing it. And the major basis for doing this should be data-driven. Then when it comes to review meetings, again, we wanted them to move from a qualitative approach to mainly a quantitative data-based quarterly review meetings. Next. Next. So this is the methodology that we adopted. We had a pilot in 3 of the districts, and the aim of the pilot was to generate evidence on the feasibility of the approach. This was done, and then an evaluation was done in the three districts. And from that, we were able to actually generate an article which was published in the Union Journal. Unfortunately, we didn't use the evidence that we got to actually inform how to roll out the approach. So we then started off with the training of provincial health executives, assumption that once they were trained, they would then be able to cascade this to the other officers within their respective provinces and districts. So unfortunately, these cascades did not happen and things were still stuck. One person would be trained and would just keep the knowledge to themselves. So in 2016, we then decided to focus on a different approach, and the training was then focused on districts. These were district health executives. And once those were trained, they would also train their facility healthcare workers. From 2018, 2019, 2020, we have now been focusing also on the lowest level of the health system. To facilitate the rollout, we have the data guide, which has been revised to have a second edition. And currently the training is in 2 phases, 8 days of theory and 2 days of field work. And the total duration of training is 10 days. So basically, as we are rolling out, the key lesson learned was that as much as possible, use your research findings to inform programming. And then as much as possible, the focusing on individual capacity building perhaps doesn't work unless those individuals, you have got a mechanism of keeping them motivated to do the cascades or to support them to make the cascades happen. Next. Oh, jumped. You moved too fast. I think there's one. Yes. So this is just an illustration of the coverage of the training so far. In some provinces, we have reached 100% of all the provincial leadership and district leadership trained. In some, we are still lagging behind, mainly because issue of resources. Where we have trained, we can actually see that there is a tangible improvement in all aspects of TB programming. Next. Slides are lost. Yes, yes. So in terms of the outcome of the trainings, after the trainings, we could see that the provincial and district leadership in the health ministry were able to conduct data-driven support and supervision, data-driven performance review meetings. They also showed ownership of the data which they produced, both at province and district level. They were now using the data for planning and decision making. They were also able to conduct mentorship on-job training activities on how to do this approach in terms of quality data collection, data analysis, and data utilization. And they could actually tell whether this report is making sense or not making sense. So that has been some of the tangible outcomes of the training. Next. So what we saw is that those who are trained submit accurate data, they submit complete data, and they submit reliable data. They were also able to tabulate and analyze and identify what are their program strengths and weakness. They were also able to do cascade analysis to identify operational objectives, operational issues which are making them fail to achieve the intended targets and the objectives and goals. They were also able to do a root cause analysis to identify what are the real challenges or problems affecting the performance of the program, because I think once the health care workers don't apply the root cause approach to identifying their issues, they end up focusing on the wrong problem or on the wrong cause as a problem. Next. In terms of best practice, there are some districts which have performed exceptionally well because it's not just the training on its own. Once you train, you also need to continuously provide some continuous support so that they feel well motivated. For Umzingwani, all their health facilities in the district continue to use the concept. Some have applied the concept to other programs. In Marondra district, they've now used it for administration, for water and sanitation programs. In Matobo district, they've actually combined this approach on result-based funding activities. In Berengwa, one of our districts again, this approach has been used for EPI and water and sanitation hygiene programs. Next. We had a visit during the AP review from Francis. Some of you might know him. As he was visiting, he was also impressed and tweeted about what we saw on this approach. Next. So in terms of lessons learned, I think with the data-driven approach, we can see that it optimizes data analysis processes by providing a new lens to proactively interrogate the routine data. Knowledge and practice gaps obtained amongst healthcare workers can easily be identified. The collective group data analysis has allowed knowledge exchange and sharing of best practice amongst healthcare facilities and healthcare workers. And the data-driven analysis identifies specific challenges and informs on specific action points to avoid ambiguous solutions. It also fosters teamwork as analysis and actions require team effort. And lastly, as I said, you can adapt to other health programs. Next. So this is just an example to show the TB, presumptive TB screening cascade for Marondra district, where you can see that before the training, the loss along the cascade were quite huge. But after the training, there was an improvement comparing, for example, Q1 of 2018 and Q1 of 2019. Next. Again, for Marondra district, when you compare using the approach, they could actually be able to account for what is happening to their patients, whereas before that, they would just send everything like this, a picture of 23% not evaluated, but after improvement of knowledge and skills, they were able to actually take more time in doing what needed to be done and evaluate almost all the patients. Next. So some of the key lessons that we've learned is that training of district teams is better than training individuals. The concept promotes teamwork within healthcare settings and also at provincial level. The support and supervision visits are no longer haphazard, but more focused because they are now informed by the data as to the problem areas. We can see there's local ownership of data, and combining this approach with the district health information system has greatly supported this approach, because you can pull out and tabulate data within a few minutes, a process that would take up to days if someone was just trying to do it manually. So we are using more and more the DHIS2 system to support the application of this system, of this approach. Next. So we also saw that the approach strengthened real-time evidence-based decision-making, and where trainings have already been done, positive changes are apparent. The analysis of data is now starting at the point where it's generated, which is at the health facility level. And we see that each site makes an effort, and a good one, to go through their data first and identify strengths, weaknesses, and action points, which are then submitted with the reports. The district level monitors the network of facilities, identifying both the hot and cold spots for early case detection. Local staff are more motivated and empowered, and they are owners of their data, strengthening the quality, the content of supervision, follow-up of training, supplies, and ultimately patient care. Next. So in terms of key message that we could share is that a good program should demonstrate effectiveness and impact from investments made by government and partners. And quality data should be generated from the source, and implementers can only generate quality data if they understand its basis, if they are confident to analyze it, and if they can use it to improve the services they provide. The data analysis and utilization guide, which we now have a second edition, goes a long way towards improving TB program ownership and performance by the lower levels. Next. So in conclusion, I think we can safely say the concept has strengthened TB prevention, control, and care activities and improved the performance of the program. The concept is feasible to implement. The concept strengthens the health systems as well as it can be applied to any of the health programs. Next. Thank you very much for your attention.
Thank you, Dr. Sandy. I get so excited whenever I see the data. Our next speaker is Dr. Lorraine Mugambi Nyaboga. Dr. Mugambi Nyaboga is a public health specialist in Kenya, currently undertaking a doctorate in public health. She has over 15 years health management experience in private, faith-based, and non-governmental organizations. Lorraine is the current chief of party of the USAID-funded TB Accelerated Response and Care Program in Kenya through the Center for Health Solutions in partnership with the NTP. Dr. Lorraine Mugambi Nyaboga will be presenting on TB data for action in child and adolescent TB. Over to you, Lorraine.
Thank you very much, Dr. Jen. Greetings, everybody. It's good to be here, and thank you for the opportunity to present on some of the lessons we've learned, as well as the process of how we went about engaging TB data for action. So this is just an outline of what I'll be sharing today. Of importance will be the key results and impacts from what we have been doing in the last 4 years or so, as well as a little bit on the impact that COVID has had on local data use and some adjustments that we've made. Next slide, please. So in terms of our background, we know that Kenya is one of the high burden countries for TB, TB-HIV, and multi-drug resistant TB. Initially, and I think even currently, TB programming is mostly parallel at all levels, so mostly in silos. And what we noted following the National Prevalence Survey that was conducted in 2016, that we were missing a lot of TB cases in the health facilities as well as the communities. And so one of our key aims of engaging TB data for action was not only to strengthen data use at local levels, at all levels, but also to support the process of increasing TB case finding. And we noted at that point that our NTB strategy indicators were below target, particularly on case finding, as well as TB preventive therapy for children under 5. At that point, following the devolution of Kenya, we had expansion of TB control regions from the 12 regional regions to 47 counties. And we noted that there was some loss in TB expertise. Yes, and so this was another aim for us to address through engaging the TB data for action. Next slide. So TB service delivery takes place at all levels. We have 47 counties managed by 49 county TB coordinators. In these counties, we have sub-counties that are run by the sub-county coordinators. And we have various over 4,000 TB treatment sites, over 2,000 diagnostic sites, and quite a good number of gene expert sites. These are linked to the peripheral health facilities through robust sample networking systems. And we have over 600 drug-resistant TB treatment sites. Next slide. So some of the key aims or objectives of the union training were to, number one, strengthen data-driven mentorship and supervision at all levels. Of importance was really to evaluate and analyze the subnational data so that we could better provide feedback and support healthcare workers who are taking care of the TB patients. We also wanted to strengthen data-driven programming, where our key agenda was to use data to identify priorities for interventions and to develop very specific, measurable, achievable, realistic, and time-bound objectives and action plans. Additionally, we also wanted to use data for policy making and advocacy at various levels. And lastly, we needed to ensure that all interventions were sustainable and cost efficient. Next slide. So the focus of these trainings really were the county and sub-county coordinators of TB and leprosy in Kenya. These coordinators ensure quality of care for our patients, and they are the link between our healthcare workers, our patients, and our national TB program. The coordinators visit health facilities every month, and they update TB data in the TB National Surveillance System called TIBU. And one of their key roles was to ensure that subnational data was used for local planning and programming at county level. However, this was one of the areas that we noted had significant gaps. Next slide. So a small team in Liverpool during the 2016 Union Conference sat together and conceptualized the idea of TB data for action trainings in Kenya. And really, this was a collaboration between the Kenya National TB Program, the USAID-funded TB Act 2 program that is run by Center for Health Solutions Kenya, WHO Kenya, and the International Union Against TB. So the plan was to conduct in-country trainings that were tailor-made for Kenya's needs. These trainings were to have the same level of standards, international standards of the trainings that had taken place, but the key mandate was to ensure that we focused on the use of data to guide national and global NTB targets. Additionally, another objective was to build up a pool of local expertise to support trainings and follow up the various counties and sub-counties once trained. And so we really focused on building the capacity of county and sub-county coordinators, but then went on to expand this to include the national level program officers, as well as implementing partners who support TB at subnational levels. Next slide. So the key components of the training include, of course, preparing some pre-course material, particularly data tabulation for all levels at facility, sub-county, and county levels, and really here focusing on the data as it is in the surveillance system. Then field practicals where we would validate the TB data within the TB surveillance system, TBU, and what was on the ground. And then, of course, evaluating the health systems, things to do with sample networking and supportive systems at facility, sub-county, and county level. There was also classroom-based sessions. Then we had feedback sessions where we would provide feedback to the different counties where the field practicals were taking place. And then lastly, we developed action plans that were smart and that identified the various strengths and weaknesses in the specific counties, as well as the indicators that were reviewed. Next slide. So looking at the TB data for action, what are some of the results that we were able to note? So on childhood TB, we begin with a national level approach where, next slide please, we were able to note that between 2017 and 2018, we had a significant increase in childhood TB case finding. This is also the period when we were able to register significant increase in TB case finding in general across the country. And the proportions of childhood TB cases across the country were increased during this period. Next slide. At national level, we were able to report that we have conducted 11 rounds of training since May 2017. We have trained 47 out of a total 47 counties. We have trained 357 TB coordinators out of 398. And we've also trained 32 national level program officers. The training for the national level officers really was to focus on supporting the various counties and sub-counties, really ensuring that there was a lot more data-driven technical assistance, but more importantly, development of regional desks. These are teams of multidisciplinary teams made up of different specialties that are linked to various counties to support them, to ensure that the various counties are well empowered to review their data, to identify their strengths, weaknesses, and to develop smart work plans, but more importantly, to follow through to ensure those work plans are being monitored and addressed. We have also developed a 16-member pool of local faculty. Again, these are specialists in all areas, TB, HIV, DR TB, childhood TB, and so forth. We are planning to complete our trainings. However, these plans were disrupted during this 2020 COVID season, but this is something that we think we will continue in this coming year. And we have been able to develop additional instruments to support local data use. For example, the facility level program charts, there's a snapshot of that right there, the mortality audit tools, as well as a data-based balance scorecard. Because of this, we've been able to have a rewarding system that is based on data. And because of that, we've seen a great response with counties looking to outperform other counties because of that. Next slide. At subnational level, next slide, we've strengthened the comparison of national, county, sub-county, and facility performance. So looking at case notification, for example, this is a snapshot of one county's presentation. Some of the things we've been looking to strengthen, and we've seen a lot of counties do, is to evaluate their case notification rate, for example, against how the country is performing, to break down performance to sub-counties so that we can then drill down to facility level as well and determine in a sub-county, for example, which facilities are not performing very well. Next slide. Additionally, looking at childhood TB cases in particular, we've gone ahead to do the same where we evaluate counties based on the national average performance to look at sub-counties based on the county performance, to break down the sub-counties to facilities and use strategies like which facilities are not reporting any children or which high volume facilities are not reporting any childhood TB cases and so forth. Next slide. An important approach we've been using is to ensure that root cause analysis is employed during development of the SMART action plans. We noted that without really looking at the reasons why specific weaknesses or challenges take place, it would be difficult to identify which action points would sort of respond accurately to the various challenges. So this is just a snapshot of a root cause analysis to look at the low county childhood TB notification of one particular county where it was 3% compared to the national average of 7%. Looking at the root cause analysis, asking ourselves why these facilities, over 60% of facilities were not reporting childhood TB cases. We noted several reasons, such as inadequate capacity, low index of suspicion, inadequate tools like SOPs, job aids, and so forth, poor integration with maternal and child health, nutrition, and so forth, inadequate contact tracing, and all that. And so once we went into the root causes, development of action points, therefore, became a lot more specific and responsive to these challenges. Next slide. And then, of course, an integral part of this process was target setting, evaluating where each county, facility, sub-county was, and using data to determine what realistic targets were necessary to ensure that a lot of effort was being put in, but effort that would help us realize realistic achievements. Next slide. So in terms of the impact at subnational level, we've seen a general increase in case finding across the board. As you saw, we began trainings in 2017. We noted an increase between 2018 and 2019. And this not only was at TB case finding in general level, but also at the childhood TB level. And then we've had an increased focus on childhood TB, looking at child contact management, for example, TB preventive therapy, and so forth. We've had the union-trained counties using their skills to identify gaps and also share their work plans at performance review meetings and forums. We've seen improvement of indicators, not only for case finding, but also for outcomes in various counties. And then for the untrained counties, we've seen a knock-on effect whereby they have developed skills as well, just because of that interaction with counties that have already been trained. We've seen an increase in demand, and also we've built capacity for root cause analysis as an integral part of TB data for action and development of work plans. Then many facilities are now developing targets based on catchment populations, based on their own data. And also the view of supervision has been broadened because of the various trainings. Healthcare workers, we've seen a lot of, they're becoming more receptive towards supervisory teams visiting them and having a positive attitude. And additionally, we are engaging other managers, other healthcare workers, particularly facility managers, in using that data to make decisions. And then, of course, we've seen an improvement in quality of care, and healthcare workers are also developing skills. This is at facility level to make presentations that are data-driven. Next slide. So we know that in 2020, we had a lot of disruption because of the COVID pandemic, and these disruptions were at all levels, healthcare worker level, within the facilities, amongst the patients, and also as far as the quality of care was concerned. However, as far as data for local data use is concerned, we had to review our data, particularly because in the first quarter, January to March, we were able to already report declining case finding. We were able to note that there was a decline in the number of facility visits. And so some of the adjustments that we made in light of this was, one, to implement online data review meetings monthly and quarterly. And we've seen a lot of success in various counties. We were able to conduct quarterly online coordination forums between the TB coordinators, the National TB Program, and various partners. These forums were used for training, sensitizations, and so forth to ensure that the participants and particularly the healthcare workers were engaged. And then we used data to identify counties in order to prioritize which counties required additional support and ensuring that we had interventions through a quality improvement model. So the regional desks that were formed were, in a sense, allocated the counties that were not performing very well, whose data was not looking very good, so that then they could provide additional support. And then we ended up implementing a quality improvement approach and plan towards improving TB indicators during this season. Then in the same season, we were able to scale up the use of facility TB indicator monitoring charts, the performance charts that I showed us earlier. And at county level, we've used data to conduct focused technical assistance to high volume facilities. As you're aware, travel and movements were restricted a lot more in 2020. And so we had to use data to determine where do we focus our efforts. Next slide. So our key lessons, there were many lessons similar to, some of which were quite similar to what Dr. Charles shared. However, some of the ones I would like to just add on were facility leadership. The engagement of facility leadership in local data use was very important for us. And we noted that by using data, any suggestions made at facility level were well taken because these were more convincing. And then understanding data was useful in helping us and helping facilities apply measures to address the challenges. Of course, using catchment population was very important. And then the use of data ensures that the relations between managers and their supervisees is very objective in terms of giving feedback regarding where one is doing very well and where one needs to strengthen. And then we've noted that the continuous robust engagement of facility in charges is very important to strengthen that local data use. We've noted that for childhood TB in particular and adolescent TB, we must integrate maternal and childhood clinics, nutrition clinics, inpatient wards to develop screening to diagnostic and care cascades so that then we are able to monitor our children and adolescents across the board. Maybe just to mention something here is there's need to ensure that childhood TB data is disaggregated because we've noted a lot more now that adolescents, or when you think of children, this is a very broad group of children, I would say. And there's need to disaggregate that data so that we can evaluate the different age groups better and determine where we need to put a lot of effort. Like I've said, this group is not homogeneous and there's need to disaggregate that data. And on issues data quality, the data has to guide us on where the gaps are. And this can only be done if there's a lot more strengthening of documentation. And then, of course, using data for quality improvement projects and emphasizing child contact management as the backbone of TB preventive therapy. Okay, next slide. I believe this is my last slide, and I would like to acknowledge all these different individuals and organizations that we work very closely with. Thank you very much. Over to the chair.
Thank you, Dr. Lorraine. It's just really so exciting to see data empower both individuals as well as the program in being able to pivot during the COVID response. Please remember for all of our participants that you can enter questions for any of our speakers into the chat box at any time during this webinar, and I've noticed that a few of those have started to come through. Our final speakers today are Megan Peterson and Dr. Alice Wang. Megan Peterson is an epidemiologist with CDC Atlanta, working in the Global Tuberculosis Branch. Her work focuses on creating improved analytic tools and promoting data use for program improvement. Dr. Alice Wang is an epidemiologist also with CDC's Atlanta's Global TB Branch. Her focus has been on TB surveillance, and she has been involved in strengthening surveillance systems and data use in multiple countries. Megan and Dr. Alice will be presenting on alternative tools for cascade analysis, the DICE Toolkit, and Elevate. Thank you both for joining us today, and over to you, our CDC colleagues.
Great, thank you. My name is Megan Peterson, and I'll be sharing the Diagnostic Cascade Evaluation Toolkit, or the DICE as it's been called. And I thank you all for the opportunity to share our experiences with this in this forum. Next slide, please. So beginning with what DICE is, the DICE is an Excel-based tool that measures gaps in the TB diagnostic cascade. So it was developed under the umbrella of a larger project, the Clinic Lab Interface Continuous Quality Improvement Project, or CLIC, which used this tool for entry and exit assessments with the added component of CQI workshops in between. So I won't be talking more about CLIC on this call. I'll just be focusing on DICE as the data collection element of that project. So DICE was piloted in Nigeria, where it has since been adopted by the National TB Program, and Uganda is also working on adopting it. The tool is intended to monitor all individuals identified as having presumptive TB, both HIV positive and negative, but it's also highly adaptable and can be used for specific populations like pediatric cases. This pilot was completed in 2019 and has now been incorporated into routine MNE visits in Nigeria, that is. Next slide, please. So how is the tool used? The toolkit collects data from multiple locations in the diagnostic cascade and basically just compiles it, which allows facility staff to visualize their gaps and drives improvement. The tool includes aggregate and patient level analyses. In the case of Nigeria, we used registers for all this data abstraction for ease of the assessment. For the aggregate, counts from a designated period are abstracted, compiled to provide data on the proportion of patients moving from one step to the next in a cascade. The patient level data collection is then done on a sample of patients to spot check the findings from the aggregate level analyses. And then patient level data also provides us with turnaround times and the ability to check for data quality between different data sources. So just as a note, no personally identifiable information, is collected in the toolkit. Next slide. So to use this tool, we would typically begin with a walkthrough of the patient diagnostic cascade and the associated documentation to identify the data sources at each step. So in the case of Nigeria, we began at the patient entry points with the presumptive TB register, then continued on to a sputum collection point, which was also documented in a presumptive TB register, then to the TB laboratory for a TB lab register, and finally back to the TB DOTS clinic for a TB treatment register. The data elements that we collected are shown here on the slide, along with potential other data sources, and these again can be modified depending on what cascade and what steps a program is interested in looking at. Next slide. So now moving to some snapshots of the actual toolkit. So the data sources that are identified during a walkthrough are then built into the DICE and by creating job aids. So here in this screenshot, you'll see that each data source identified has its own tab, which is associated with a job aid. Next slide. So once built, the job aids will look like this, where the fields across the top mirror the fields in the data source for ease of abstraction. And this really did help to speed up the assessments and make this easier for folks to learn. This was used for aggregate data collection, what's being shown here. So each row in this sheet represents the count totals for one page in a register. Next slide. So the data from these job aids is then auto-populated within the DICE into figures, including this main overview of the cascade that I'm sharing here on this screen. So this visual moves from all of those with presumptive TB, starting with the number 1, to those with a specimen collected, received by lab, tested, had a result transmitted back to clinic. And then that huge drop there between steps 6 and 7 is for those that were positive. So from those that were positive, we continue down the cascade for whether they started TB treatment, and it can also be captured whether they completed TB treatment. So using this sample cascade, a site would be able to see that a large gap exists at the beginning of their cascade, where only 78% of collected specimens actually made it to the lab. And they could also observe that only 46% of patients were successfully treated. These are, again, just sample data and just examples of things that we've kind of trends that we've seen or gaps that we've seen identified when this data is compiled from the multiple sources. Next slide. So some additional analyses that are built into the tool include these that are shown here. Number 1 shows a summary of TPT initiations. So the tool can be used to measure TPT initiation and completion. And number 2 gives a demographic breakdown of those with presumptive TB. Number 3 is a data quality check between data sources. And number 4 is a turnaround time analysis from patient level data. I should mention that this version of the DICE did not include the step of TB screening. That's up one step in the cascade from where we started our measurements, but the tool, I think, could be very useful in assessing this step as well, and we'd like to see it expand in its utility and go in that direction. Next slide. So after these assessments are completed, staff are brought together from the clinic and the lab to review the results and discuss issues in process and documentation, which leads to improved understanding and coordination throughout the cascade. In Nigeria, staff then attended CQI workshops as the broader CLIC program, and this data served as the starting point for developing improvement projects and M&E metrics. I will say, though, that numerous sites reported already having taken remedial action when they arrived at the workshops, suggesting that being armed with the DICE data alone was a powerful tool for site improvement. Next slide. So this concludes my brief presentation of the DICE, but I've included here a list of other individuals who contributed to this work. And also, we are developing a full package on the CLIC program, including this DICE toolkit, which ASLM plans to publish and make more widely available, hopefully soon. So thank you very much.
Hello, thank you for the opportunity to introduce Elevate. which stands for Engaging Local Experts to Validate and Analyze TB Data to End TB. And this was a program designed and implemented across all 24 districts of Mumbai, focused at the district level with the intention of using local data for impact. Next slide. The components of Elevate included a 2-day workshop. We know that district TB staff are very busy and we did not want to pull away from routine activities. So we kept the workshop concise and relevant, focused on data quality and analysis of their own district data. Another aspect of Elevate was an Excel-based dashboard, which I will describe later on. We created a guide with workshop highlights and that served also as a dashboard user guide. Finally, the last component and the most important component was mentorship through on-site visits and guidance. So the objectives of Elevate are to help district staff understand programmatic data is not for reporting, not just for reporting, but can be used to drive action and improve TB outcomes. To think critically about data quality and recognize that data are not going to be useful unless data quality are improved. Analyze and use routine TB data at the district efficiently. Interpret and present data in an easy and meaningful way to improve program performance and patient management. And in Mumbai, TB programmatic data can be exported in an Excel table from the TB surveillance system, Nikshay. Additionally, staff were comfortable using Excel, so we decided to focus on outcomes of building capacity of Excel functions, formulas, and pivot tables. Next slide. Boiling it down to some very simple steps, this diagram is the Elevate framework for using data for action. First, we ask questions of our data, maybe based on observations we noticed in the district. Then we see how we can best answer our questions with our data. Since our data analysis is reflective of data quality, the second step is to ensure our data are clean to improve data quality. The third step is then to analyze our data, followed by interpreting the analysis and using it for data-driven action. Next slide. A reason why Elevate was so relevant was that it was designed around the participant's job and having hands-on activity with district data. For example, this is the mental model of the TB clinical cascade. We structured tools and workshop around this mental model. For the clinical care cascade, we first looked at characteristics of the presumptive TB patient. Then we looked at diagnosis based on the exam and whether or not resistance was detected. Then we followed the patient through treatment and treatment outcomes. Next slide. Based on the care cascade, we organized Nikshay TB notification register variables, and we use this as a basis for data quality and analysis in the workshop, as well as designing the Elevate dashboard. Next slide. Based on feedback from several district TB officers, we designed the Elevate dashboard tool, which contains 3 profile pages. This is the Epi profile, which gives an overview of a unique epidemiological profile for each district overall and by TB unit to understand the characteristics of TB patients. Additionally, we've added slicers to look at specific time periods, drug resistance, and whether patients are from public or private sectors. Next slide. This is the notification and resistance dashboard profile, which examines TB notification over time, resistance, and differential testing practices. It is important to look at patterns of disease over time, and comparing testing differential sheds light on program performance. Next slide. This is the treatment outcomes profile, which examines delays in anti-TB treatment and final treatment outcomes of new, retreated, and missing patients. This information is important for looking at trends of treatment delay and comparing treatment outcomes across different types of patients by district and sub-district to improve patient care. Next slide. During the workshop, districts were asked to come up with 3 top questions, and throughout the workshop, data cleaning, analysis, and discussion were all focused on these questions. After the workshop, districts could continue to follow up on their priority questions and take actions and implement interventions to address the issue. Next slide. A few examples of the priority questions and actions taken from the Elevate were that one district had used the dashboard to decrease treatment delays in near real time. Another district investigated missing outcomes, especially with the variable of HIV testing, to ensure that all TB patients get HIV tested. Another district worked closely with the private sector to improve the utilization of CD/NAT testing, since they saw a testing discrepancy between the public and private sectors. Next slide. A follow-up checklist was developed and conducted at post-workshop mentorship visits. These visits were conducted quarterly by our implementing partner, Share India, along with a Mumbai city-level TB officer. The checklist touched upon data quality and cleaning, analysis and archiving, data use, communication, as well as the progress of the 3 priority questions asked by the district. Next slide. Over 94% of participants agreed or strongly agreed that skills gained through Elevate were useful for their job, will improve the way they do their job, and improve the quality and analysis of TB programmatic data. Elevate was found to be very useful and well received. Next slide. Based on the success of the Elevate framework, we're developing Elevate 2, or E2, to expand across multiple states in India. There will be 7 data analysts hired to work with the Central TB Division and follow a training of trainers model to build capacity at sub-district levels. And I wanted to acknowledge that all this effort was made possible with our collaborators listed here. Thank you.
Thank you, Dr. Alice and Megan. There's been a couple of very good questions that have been going on in the chat, and I would like to actually bring them so that everyone could hear them in case you missed. The first question was by Dr. Graham around the issues of targets that were raised both in Dr. Sandy's and Dr. Lorraine's presentations. And that question was, do you think that the setting of targets is useful for continuous quality improvement, or perhaps can they be counterproductive, such as encourage poorer data quality? And Dr. Sandy, I know that you answered some of this in the chat, but can I call on you first and then Dr. Lorraine both to comment on this issue of setting of targets?
Dr. Sandy or Dr. Lorraine, if you're talking, you're on mute to respond to the question.
I'll allow Dr. Sandy to go first.
Thank you. Do you know what, Lorraine? It appears that Dr. Sandy is having some problems with
No worries.
So could you go
Okay.
for that one first?
Yeah, I can go ahead. I was trying to read the question. I didn't hear you very clearly. So let me just see. The question is, do we think the setting of targets is useful for continuous? Okay, got it. So I think for continuous quality improvement, the main tenet is looking at the data, agreeing where the strengths or weaknesses of that data lie, and then determining how or what inputs do we put in to ensure that we move from, say, an 80% treatment success rate to an 83% treatment success rate. So target setting in this case is important, but I think more importantly, and in alignment with the principles of CQI, there is a need to look at the small systemic changes that we have to put in place that will then impact the data. So it's not so much about the data itself. The targets are just an endpoint, but also the system itself, looking at what is it that's not helping us achieve that target of, say, 85 or 90% treatment success rate. I think that's what I would say on that issue. I hope I've addressed it. Thank you.
Yes, thank you, Dr. Lorraine. And just to note, Dr. Sandy in the text actually mentioned that one challenge that he notes in target setting is that if you set over ambitious targets, that this can be counterproductive by be deemed demoralizing.
Yeah.
Okay.
Absolutely.
Dr. Lorraine, there was one other question, I think also from Dr. Graham that was very important, and that was about the age groups that you would ideally like to see for disaggregation among children.
Okay, great. Thank you very much, Dr. Graham, for that question. And I think this is an area we've been discussing a lot with the National TB program here in Kenya. The fact that children really are a large group that's not homogeneous. Like we said, adolescents in particular do not receive much attention as far as TB is concerned. We really lump most of our patients either within the childhood TB group of 0 to 15 or the adult group of above 15. But then remembering that adolescents are sort of astride those two groups and their needs are very specific. They have all these hormonal changes. There are issues to do with adherence. Many of them, particularly in Kenya, are in boarding schools, etc. So their needs are very different from, say, a child between the age of 0 to 5 years or 5 to 9 years. So in terms of disaggregation, I think the proposal we have would be that that disaggregation will help even in terms of evaluating the cascades for these specific age groups. And so my proposal was to have this disaggregation into the normally or standard the groups that we use in other programs. For example, maternal and child health, where they have the under 5, the 5 to 9 age group, the 10 to 14, and the 15 to 19. That way, we can then ensure that the adolescents are taken care of within the 10 to 14 and 15 to 19 age group, while the children are taken care of, or the younger children are taken care of between the or within the age groups of under 5 and 5 to 9. But I think more importantly is that evaluation of those cascades versus evaluating just under 15 and above 15. Thank you. Over to you, Dr. Jen.
Thank you, Dr. Lorraine. Gobili, forgive me if I pronounced your name wrong. I think you have your hand up. Can you unmute and ask your question, please?
Oh, thank you very much. I wanted to respond on the issue of targets. I think it was well answered by Dr. Sandy, but also in addition, like what Lorraine has said, targets will not be an end in itself. Let's take, for example, if you set a target for treatment success to be at 90%. So when you analyze your data, let's say using trends, and you look at a facility and you look at that facility for the past 3 quarters, in the first quarter, the treatment success rate was 96%. The following quarter, it was 94%, and the other quarter, it was 91%. So if you look at that facility, although it may be above the target, but in terms of this concept, we will say it's not performing well because the performance has been declining over the quarters. So yes, they may be above the target, but in terms of progression, there is a negative progression. So that's the challenge with the targets that I see. And also in terms of disaggregation, yes, in Zimbabwe, in terms of notifications, we have clearly demarcated disaggregations from presumption, actually. 0 to 4, 5 to 9, 10 to 14, and 15 to 19. So we can be able to extract and focus on performance with particular age groups. I think in the slides that Dr. Stanley shared, there are 1 or 2 slides that look at the data of notifications in terms of these disaggregations and also on presumptive TB cases. Thank you. Over.
Thank you very much. I think the whole discussion about targets is actually incredibly important, that they are a tool and not an end all. I'd like to actually take a minute and go over to Dr. Hassan Mataka of the Tanzania program to share some of the thoughts from Tanzania on using their experience with using data. Over to you, Dr. Mataka.
Thank you, colleagues. Thank you. Our experience in Tanzania in the year 2019 November, we did an epidemiological data analysis for childhood TB in Tanzania, where we check the trend for 3 years, 2017, 2018, and 2019. And that analysis was really helpful for us because we had to make a national strategic plan number 6, which we use those data. We generate evidence from those data. We get the facts, the gaps, and the lessons learned at the different areas in childhood and adolescent tuberculosis. And moreover, we check the status for HIV, status of the group age disaggregates 0 to 4, 5 to 9, 10 to 14, and 15 to 19. We deep dive on the geographical, referral mechanism, nutritional status, poverty situation, and the treatment outcomes, and the success rate for all those areas. Furthermore, we check even the mortality rate by HIV status, by geographical. We check on the diagnosis method used for children and the data quality review. So for us, that was a very useful exercise. It informs us a lot, and it's a document we use up to now to pave a way and plan our interventions toward the children's based on what we had in our data. Thank you. That is at least a short I can share with the colleague. Thank you so much.
Thank you so much for sharing that experience from Tanzania. We had one other question that I'd like to go back to be sure that it's actually captured on the record. And this was the question to Ms. Peterson from CDC. And the question was from Kobto Kura. And it was around the issue of focusing on, why do you focus on patients with job aids? And could you give some more explanation about the cascade? I know, Megan, you answered this in the chat, but could you just come off mute a moment and answer that for the whole group? Thank you.
Sure, I'm happy to do that. So the job aids were really something that was developed to help us use registers as a data source, because it can be quite difficult to abstract over a long period of time from a registered data source. We created these to mirror the registers and make it easier for the people using the tool to make sense of what we were asking them to put into the tool. If you were using something different, say an electronic data source, perhaps these registered job aids would not be relevant for your setting. So hopefully that clarifies the question on job aids a little bit more. As to the cascade, we referred to, well, we use the word cascade to refer to all the steps that need to happen along the pathway of a patient being detected as having symptoms, to being diagnosed through laboratory testing, to being started on treatment and completing treatment. So the toolkit really worked to bring together data from each of these steps and compile it into one place so that folks could see it side by side and see where people or even where specimens weren't making it to that next step, so that they could focus efforts and try and figure out what was happening there. Thank you.
Thank you for clarifying that. I'm just going to take a moment to look through to be sure I haven't missed any raised hands. If there were any other questions, if there is, you can just come off mute and bring your question to the fore. Okay. Not seeing any other hands. I just want to note that I feel like this discussion has been extremely helpful. And I hope that it'll help guide our member countries on how to use high quality child and adolescent TB data to develop and improve TB care cascades for child and adolescent TB, MDR TB, and in fact, almost any subset of our TB care and prevention issues. Now, what I'd like to do is to actually welcome Susan Maloney, the chief of CDC's Global TB Program, who's also part of the COE's advisory committee, to give us some closing remarks for this wonderful webinar. Over to you, Susan.
Oh, thank you so much, Jean. And thanks to everyone. I said it in the chat, but I'd like to say again, thanks to the speakers today for some wonderful presentations and for sharing your expertise. And also thanks to all the participants for joining what's been really an engaging and thoughtful discussion. I'm hopeful that we can continue to share these approaches and tools for TB data use. And this will contribute effectively to national child and adolescent TB response at all levels and help us find more children and adolescents with TB and include them in preventive therapy and help strengthen the quality of TB services within our member countries. The COE, all of us, we look forward to continuing to use this platform at the Center of Excellence to encourage sharing of additional best practices on how to use high quality child and adolescent TB data to develop and improve TB care cascades for child and adolescent TB and MDR TB. So thanks so much. I will turn this over now to Rita.
Thank you very much, Dr. Maloney. I would like to echo your sentiments and thank each and every one of us. We have been a record crowd attending the second COE webinar for the founder member countries. And this session has been particularly special regarding the fact that we have had some observers. I wish to mention that perhaps you saw among the participants names that you do not recognize from the 9 COE member countries, mainly Northern, Eastern, Central and Southern African Anglophone countries. We have had observers from our Francophone team led by Dr. Kopto Kora, and this team is seriously considering taking up data interventions in order to strengthen their TB care and prevention activities. So we are more or less on time. I would like to mention to you that John Paul is going to send you a follow-up email shortly. This email includes an evaluation survey, and we would really like you to take a moment to fill it in and give us your feedback. What did you like and what do you wish to for us to improve in the future webinars through this survey. We will also share the recording of this webinar with all of you, and we will also send you some additional reading materials that you may want to refer to in future work on TB data. If you have any questions, do not hesitate to get hold of Dr. Maloney at CDC or Drs. Wang or Peterson, or myself or John Paul Dongo regarding the union's interventions. And on behalf of CDC colleagues and the union, COE and myself, once more I would like to thank you most sincerely for making time this afternoon for joining this webinar. Have a very good rest of your day. Keep safe and keep on masking. Thank you, everyone, and bye.
Thank you.
Thank you. Bye-bye.
Thank you. Bye.
Thank you. Bye-bye.
Thank you.
Thank you.
Bye.
Bye.
It was awesome. Thank you.